Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features expert insight from a virtual webinar titled ART Safety and Tolerability, a focus on aging patients in populations with cardiometabolic toxicities, featuring Dr. Marta Boffito, consultant physician and professor at the Chelsea and Westminster Hospital and Imperial College of London in the United Kingdom, and Dr. Jens Lundgren, professor at the University of Copenhagen in Denmark. In this episode, they address questions about ART safety and tolerability in key populations, such as aging patients and populations with cardiometabolic toxicities. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what our expert faculty have to say about this topic.
I can see that there is a question from Heather. And Marta, just to bring you in here, because I know you have also extensive experience with this, and maybe we can debate it here. The question from Heather is, on the lipid panel, which parameters are most changed? And are there known changes in VLDL or other parameters? Marta, you want to give a stab at that? I'm happy to follow up.
Yes, thank you, Jens. The cardiologists that we work with are very much insisting on total cholesterol, LDL. The ratio is important. And now the non-LDL cholesterol is also something that they are really looking at. Let me give you a practical example. So we're quite lucky at Chelsea Westminster Hospital, where I work in London. We actually are able to perform coronary artery calcification scores for people who are living with HIV and are above the age of 50. And when the coronary artery calcification score is between 50 and 75, we don't need to refer to the cardiologist, because what we are asked to do is to actually make sure that we aggressively treat the cholesterol and make sure that the total cholesterol is below 4 and the LDL is below 2. So those are really what we should focus on. And I would say that when we see people that are presented with the cardiometabolic syndrome, with the metabolic syndromes, those are the ones that are raised, and those are the ones that we want to intervene to. So that's what the focus is, I would say. Jens, what do you think?
No, I think that makes a lot of sense. I'm really intrigued because you say that you are screening patients older than 50 and assessing the coronary calcification score. Maybe we should speak a little bit about that. Obviously, that's an assessment. The evidence for this is evolving. Can I ask you, Marta, how frequently are you doing that comprehensively in all patients older than 50? Because I guess the context here is, and I think many clinicians will remember that typically, we judge whether, for example, statins is indicated based on sort of the underlying cardiovascular risk, right? Using one equation or another, Framingham or what have you. And if the 5 or 10 year risk is above a certain threshold, then you would recommend starting lipids. But using the coronary calcification score, obviously a much more direct measure of the individual person's atherosclerotic process. So how comprehensively are you doing this? Doing it all? And if so, how frequently are you doing it repeatedly? Can you speak a little bit about that?
Yes, absolutely. So we do it as a one-off, actually, which is probably not the best you can do, but this is what the service has the capacity to do. We do it as a one-off, and we actually have published that in people living with HIV, there is quite a lot of discrepancy between the equation and the CACS results. So in our cohort, some people who would have not received the statin because their equation didn't show a cardiovascular risk above 10% had a high CACS and actually needed a statin and vice versa. So it actually does help us there. But we do it on a one-off. Now, the cardiologist that runs our HIV cardiology clinic would like us to do it more often, but we have too many people to do it more than once. However, when we do it once, anytime after they turn 50, if it is high above the 75th, they get referred to the cardiology that actually reviews it in details and does request any other test, but it also works in more, again, aggressive primary prophylaxis. So this is how it works. And that's why we focus on which lipids to look and which, and how extensively we want them to change, follow the intervention, going back to the question.
Sure. No, that's very helpful and interesting how the medicine area is evolving. I sense from your answer that this is particularly relevant for people where you're in doubt whether there's an indication or not. And obviously, if the coronary calcification score is high, then that is a clear indication for starting it, irrespective of whatever equation we're using may show. Is that a fair summary? Yeah.
Yes. Can I read the next one? Jens,
Please.
There's a question from Laura saying, how strong is the evidence of increased cardiovascular risk with integrase inhibitors? So how strong is the data on that?
It's not strong data. There is one report I was referring to that, and the signal again, there was a what we call a pharmacovigilance signal of an excess risk only in the first 2 years of treatment, and then it appears to disappear. And we just need to remember that when we do pharmacovigilance for drugs which are fairly new on the market, there's a number of pharmacovigilance signals that is generated that needs to be explored. But at the same time, you cannot assume that if there is a pharmacovigilance signal, that is a causal effect of the drug. So pharmacovigilance signals are generated and reported because they allow for other studies to assess the question, do they see the same thing? And that's really what we are waiting for at the moment. And therefore, really, the evidence is not strong enough for us to take clinical decisions based on this observation. But in the drug safety science field, this is an important way to make us understand whether there is toxicity with drugs of various types, here in this instance, cardiovascular disease or not. Obviously, pharmacovigilance has been used extensively for HIV medicines over many years and have been helpful. Some of them have been confirmed, others have been subsequently refuted. So just so you're all aware, that's a normal process that happens as we get drugs, in particular drugs that we're talking about here that you give for extended periods of time, where there could be undiscovered toxicities, and as a consequence, cohort studies is using energy to investigate that.
Yeah, can I add a question to that? Because
Sure.
I don't have Jens Lundgren every day to whom I can ask any question. So I'm going to take the advantage to add to Laura's question. So the RESPOND cohort didn't correct for statin intake.
Well, there was a number in the paper. It was published in Lancet HIV. There was a number of assessments of using drugs, but also of dyslipidemia, which is called sort of sensitivity analysis to assess whether the signal identified was affected by correcting for those factors. You obviously need to be very careful once you start to do that, because the issue that we typically in observations talk about, namely confounding by indication, that certain patients are using certain drugs, and you can therefore have drugs that is very effective. If you don't control for the fact that we select out patients who are at excess risk and give them drug, it becomes a proxy for people who is more sick. So it's a very delicate analysis. Mm-hmm. But in the end of the day, to answer your question directly, Marta, that did not appear to be the explanation.
Okay, that's great. Very, very helpful. And there is a question from Marianne about the predisposition of black rays to weight gain. So do we actually think that a genetic factor that may predispose to weight gain? Why the studies like ADVANCE have seen this important weight gain in certain people, and other studies running mainly in Caucasian individuals don't seem to see the same? Do you have an opinion on that?
Yeah, I have an opinion, and the opinion is I don't know, to be frank with you.
I don't know either.
Because
I agree.
I mean,
I agree.
because I've been also discussing this extensively with people. I mean, the fear that we have when we see such a signal is this due to the population that you are studying? I mean, the signal in Black women was generated, at least initially, by studies done in South Africa. Can you actually extrapolate that? Is it actually the Black race per se, or is it in the context where the study was done that this was generated? But as you say, there are a growing appreciation that this race difference in weight gain induced by drug appears to have an influence on that. But the biological explanation for that, why that should be like that, I think is, in my opinion, an open question. I don't know, Marta, if you've heard anything, but
No,
to solidify this. But
yeah, I agree.
But I think it's really important to understand, and just as I was saying before, that we see this is obviously important to understand, because it looks like it's real, but whether we want to act on it and do something proactively because we are sitting in front of a Black woman compared to a Caucasian male, whether we want to change our advice, I think is still something I would think could be debated. Would you, Marta, if you have a patient in front of you that you think you made a good point about maybe switching, in particular older people, away from boosted protease inhibitors because of potential toxicities over to a unboosted integrase inhibitor, would you put an influence in your recommendation depending on ethnicity and gender?
So that's a very good question, which I'm delighted to answer. And I will also cover a question from Babajide about how do you convince a geriatric receiving antiretrovirals to follow lifestyle modification plans. And I'll tell you why. You'll understand why I hope to answer both. So I think that modernization of treatment is really important. I did mention why briefly earlier. So, just the reduction of drug-drug interactions. And in people with a bit of resistance, we might have to use second-generation high genetic barrier integrase inhibitors. And I would like not to exclude this incredible tool when I have to switch someone. So in this context, I believe very much in social prescribing, which again, we have linked to our clinic, a physiotherapist and a dietitian. So instead of starting saying, I'm going to give you metformin, I'm going to give you statin, I'm going to give you this, and then actually generate the polypharmacy, we're going to try to have people sign up to our Live Well pathway. So both in the context of a certain ethnicity that would very much benefit from an integrase inhibitors, or a geriatric patient who would probably struggle to go to the gym, we try to support them with our service and kind of overseen or, monitored lifestyle interventions. So we are a very large clinic where there's a lot of people living with HIV that attend. So we try to create these additional services linked to the clinic to be able to provide the best care we can.
No,
so again, rather than not give it, I give it, but I really insist on lifestyle.
No, that's an excellent, and I think, Marta, just to follow up, Elena have a question in chat. By the way, thank you, everybody. There's a number of great questions here. So Elena is asking, what about getting a nutritionist on board before the weight gain occurs? What's your take? How effective is that? And should we do it more actively?
So we have a dietitian, and we make sure that if we fear a higher risk of weight gain, a higher risk for developing the metabolic syndrome with a switch away from all the drug, we just link them with the dietitian straight away. I'm not saying the success rate is 100%. We are trying to work on prevention. And this is in general also for polymorbidity prevention. I think there is room now because we're not worrying so much on viral loads anymore. So we're really trying to work on prevention. So nutritionists, dietitian, again, physiotherapists. If it's possible, I think it's a very good idea.
And when you say we're not worried about low, obviously we are very
so yes, but we have amazing drugs.
Yeah, we have amazing drugs, but so the challenge we had maybe 10 years ago to control the viral replication has really been overcome with the drugs that we have now. So, right, I mean that's the transition from are we able to control viral replication to where there was genuine problems 10, 15 years ago has really switched now to that a number of different combinations of drugs are able to do this. So how do we figure out how to actually manage other factors on top of controlling viral replication, right? Marta, that's it's been a very dramatic transition in how management and care has been possible in the last 1 or 2 decades.
So to follow on this, there's a question from Tiluka saying, what treatment do you recommend to change in young people without comorbidities, only weight gain, and all diabetic people with weight gain?
So again, I think it's really also a follow-up to the comments that you made before, Marta, that I think there is general consensus that you need to have a good argument not to use an integrase inhibitor, an unboosted integrase inhibitor. We have talked about weight gain as a problem, but please understand that there is an excess risk of weight gain, but that do not mean that the individual patient will experience weight gain. So I guess my recommendation is to really follow the guidelines in this respect, and then make sure that if unfortunately there is significant and major weight gain, first of all, consider whether there's any signs of metabolic consequences of this and treat that. And then I know that there are at least some physicians, if it is pretty extreme, which it can be, although rarely, that one maybe also try to switch to another type of drug. But the complex interaction between integrase inhibitors and use of TAF versus old-time tenofovir, it is intriguing how also the type of nucleoside backbone appears to influence the risk of cardiovascular disease. We have talked a lot about integrase inhibitors, and all the issues around using tenofovir, which have renal and also potential bone toxicity, but it seems to be those on tenofovir at less risk of experiencing weight gain. Like anything else, it's a balance of things, but I don't think I want to necessarily change to address the question directly. I don't think that two scenarios, young person without comorbidities and diabetic patients, I think I would probably give both of them an integrase inhibitor. What do you think, Marta?
Absolutely. I'm glad you said that. I fully agree. The treatment is probably the same because it's the simplest, easiest to take, best tolerated, isn't it? High genetic barrier. So I wouldn't give up all of the characteristics of the modern drugs that, took so many years to become so great, but it's more the interventions around. Absolutely. And also there's a question on abacavir and cardiovascular toxicity and speculative data about TAF on this issue.
No, I mean, I appreciate that. I mean, it's been a discussion for those who's interested in history. The abacavir signal on cardiovascular risk was indeed a pharmacovigilance signal generated in 2008. Has been debated ever since. I mean, there's a number of studies that is able to reproduce this, observational studies. I know the response cohort has just published a paper as well on that point, again, reconfirming that in a separate cohort of patients. So it appears to be real. But on the other hand, and I think this has been stressed over and over again, that this abacavir signal of excess risk of cardiovascular disease, it's actually a signal that tells you that as long as you are on abacavir, your underlying risk is increased. But once you take people away from abacavir, they go back to their underlying risk. And that seems to be a fairly consistent finding Of course, this is only relevant for people who is at excess risk of cardiovascular disease. We just had a discussion about using an equation or the coronary calcification score or things of that nature. But this is really only something that you really want to pay attention to clinically in people at very high elevated risk. I think that's at least my take on it, trying to be balanced and also be respectful of the data that has been accumulating.
And if you don't mind, I'm just going to reply to the questions about cardiologists.
Please.
So we have set up a cardiology HIV clinic with an incredible cardiology colleague who just became passionate about our patients. So it's a very good question. So, how am I going to engage them to look after people living with HIV beyond the drug-drug interactions? That's a bit more pragmatic. It's a matter of fact. So I'm telling you, so the conversation we'd have with her, she's very intrigued about how advanced and complicated the cardiac comorbidities are in these people. So I think one of the message for them is that, expect complex cardiac comorbidities, expect what you see in an older person without HIV earlier. Don't hesitate to actually investigate something you would investigate in an older person earlier, because this is really what it seems that it's happening. And it's wonderful if you have cardiologists on board and you kind of subtrain them in HIV a little bit, so they really learn about managing cardiometabolic syndrome in people with HIV. I'm sure you must work with cardiologists too.
Yes, I do as well, and I agree. I think HIV management is a multidisciplinary team, and bring in expertise and make sure you have expertise available to you so you can discuss it with them. And just my last comment here would be to everybody, we mentioned different guidelines. There's the DSS guidelines, there's the BIVA guidelines, there's the EACS guidelines. Many of them have been issuing the guidelines as apps you can download on your smartphone, so you have them readily available. So there's an abundance of good and clear recommendations that you can use as part of your daily work as a healthcare professional. So from my end, thank you very much for joining in. Back to you.
Thank you very, very much.
Thank you very much to our faculty, and thank you to our listeners for joining in. Please be sure to check back for more episodes on important infectious disease topics. Thank you.